fought for years because people with mental illness have been subjected to pervasive discrimination in health insurance over time, over the last number of decades. So people, if they could get a health plan at all, it was often exorbitant. The premiums and deductibles and everything meant that it was almost not worth having it unless you had a very, very serious condition. And so people would, people feel ambivalent about getting mental health care to begin with, and so they wouldn't have health coverage. And then if you did have health coverage and you needed intensive treatment, the plan would drop you. And even if the plan didn't drop you, your premiums and other out-of-pocket costs would skyrocket if you need intensive care. So Nami has fought for parity for many years. We were instrumental in passing the 1996 Mental Health Parity Act during the Clinton administration, and then we were very fortunate to be part of passing the Mental Health Parity and Addiction Equity Act in 2008. And we call it MAPIA. And MAPIA does not actually require insurers to provide mental health care. It doesn't require employers to purchase mental health care for insurers. But if that care is purchased, then it must be on par with other types of care, with medical surgical care. MAPIA really applies to large health insurance plans, including self-funded health insurance plans. It doesn't apply to small employers. So if you come along with the Affordable Care Act, it requires 10 essential health benefits, including mental health and substance use benefits, for individual and small group plans. It requires that type of care, and further, that care must be provided, those benefits must be provided on par with other types of care. So we go from the if-then of MAPIA to the essential health benefits, which requires mental health care to be provided on par. So this is really important because, finally, mental health benefits are required in health insurance. So, but, this is a very complex system, and, things can look one way on paper and be a very different experience to people who have health insurance coverage. So when the final rule for private health insurance finally took effect on July 1st of 2014, we said it's really time to put a finger on the pulse and to get a street-level view of what it's like to try to get mental health and substance use care when you have private insurance. So we did a nationwide survey, and we got respondents from every state. Slightly less than 3,000 people responded and told us what it was like to try to access mental health care using their insurance. And that's why we wrote up this report.
And one of those statements, reading from the report, which, by the way, is entitled or subtitled A Long Road Ahead, and I want to talk to you about why that's important and why that was indeed chosen. But one of the inserts that seems to illustrate the point that you've made is this quote: "My insurance will pay my primary care doctor more for a 10-minute appointment for the flu than it will allow my psychiatrist for an hour-long treatment session. For this reason, my own psychiatrist, along with many others, no longer accepts insurance." Is that illustrative of what you're talking about, and how do you fix that?
Yeah, one of the huge problems is that people who have insurance can't find a mental health provider in their health plan's network. So even if you have insurance, finding a provider is still an uphill climb. And that's for, there are several reasons for that. One is, the difference in payment and the fact that a mental health appointment is longer than an appointment for most types of care. So ideally, an appointment with a psychiatrist is a 50-minute hour, whether an appointment with a primary care clinician is maybe 15 minutes max. So, and so they're paid at the same rate per visit rate. And that means that psychiatrists lose out, and mental health care is complicated and individualized, and it needs to be in order to address the very individual problems that we all face when we're dealing with a mental health condition. And so there's a burden of reporting that mental health providers find very difficult. They say, I came in this to help people. I didn't come in this to do paperwork. And if I have to duke it out with the insurance company every time in order to justify the care that I know this person needs, then that's really more than I want to take on, and it's more than I can afford to take on. So that means that over half of psychiatrists in the United States don't even accept insurance at all. They just do private pay. You've got to pay directly.
What's the prognosis for that? What's the future of a system that would look like or approach parity? How do you fix that?
Well, clinicians don't like this either, but I think that going to an electronic health record, which is part of the Affordable Care Act, will change care so that documenting care, you don't have to document care twice. You just document it in your computer, and just parts of it, not the psychotherapy notes, but the parts of it that are kind of countable would go into the electronic health record, and that would reduce the burden, ideally. Now, I know that health plans, they are in it not only to provide care, but also to make a profit for their shareholders. So they're always trying to balance, how do we ensure that the care that is delivered is the necessary care and that it conforms to what science knows works, versus mental health providers who may have a preferred type of care, but it really doesn't have is research that shows that it's not as effective as it could be. So they're always trying to ensure that people do get good care and that it's necessary care and that it's charged at a reasonable rate, but there's always this tussle back and forth, between the provider who says, I'm sitting here with the person, I'm understanding what they need, and I'm trying to justify what they need to you, and the insurance, which is looking at the big picture, going, well, no, that's not average, so they're going to deny care. The only hope, really, is for insurers and providers to come together with family members and really work through this. And the only way that that'll happen is if the federal government and the states who are responsible for enforcing parity, force us all to come to the table and work it out.
Is there a realistic, or let me put it another way, what's required in order for that to happen, in order for the federal government to bring the parties together? Is the onus on the general public, organizations like NAMI? Where's that push going to come from to make that happen?
Well, the push will come from the average person like NAMI, but the onus lies first on the states. Actually, states are responsible for enforcing parity, and the Attorney General in New York, Attorney General Schneiderman, has actually led the charge and has recently settled his fifth lawsuit, the mental health parity lawsuit, against an insurer, holding their feet to the fire to provide equal care, equal mental health and substance use care compared to other types of care. So that kind of enforcement through the courts and through regulation is what's going to bring the big picture around. But we, the average person, if we feel that we have been denied care and we think it was reasonable, we don't know why it was denied, we need to file a complaint. Which, when you're dealing with a mental health condition, in yourself or a family member, the last thing you want is the hassle of filing that kind of complaint. But it's really important, particularly for family members, to take this on and file a complaint with their insurance company and with their insurance commission, their state insurance commission, because it's only in gathering that kind of information that that parity will be enforced.
One of the concepts that the Obama administration introduced with the ACA is the idea of having healthcare navigators, individuals in the community that are attached to community-based organizations, to small groups, individual providers that help folks negotiate and figure out work their way through the system. Would something akin to a navigator to help folks go through that appeal process. Would that be helpful?
Absolutely. First of all, navigators are extraordinarily helpful in the Affordable Care Act, particularly for people with a chronic health condition such as mental illness, because they can help wade your way through the tools that do exist, in healthcare.gov to find, is my provider in the plan that I'm looking at here? How are my medications covered? What are my out-of-pocket costs for my particular medication? What are my out-of-pocket costs generally, including co-pays and co-insurance? We found with the Affordable Care Act that it was essential to have somebody that could help you walk through this, particularly if you had a chronic condition. The Affordable Care Act, the political rhetoric was, we're going to have, very simple, no fine print information available on every plan so you can compare apples to apples. But the fact is that this isn't a simple problem. You need to be able to dive in deep. You need the details. And consumers have not had the details for general private insurance. Those details are available for Affordable Care Act plans, but you got to dig deep, and that means you need a navigator, you need a guide. So if having those kind of ombudsmans or navigators to help people wade through all of this would be extraordinarily helpful.
Is there an incentive, as with the buy-in to the idea of the Affordable Care Act in general, for the insurance companies? And that buy-in and that incentive was, look, you're going to get a lot more individuals paying you premiums, and the federal government helped with that. Is there a comparable incentive for insurance companies to make mental health care more accessible for folks?
Yes, health insurance plans know that at the root of many of the health conditions people, get help for, either, underlying as a cause or as a result, people have mental health problems that compromise their ability to take advantage of health care. So, you might go in for diabetes, but underlying your diabetes might be depression, because diabetes occurs at 3 times the rate in people who have mental health conditions compared to the general population, even, not including medication. So they know that mental health is a huge part of their business, and they know that they need to get it right, both on the private health insurance side and the Affordable Care Act, not to mention Medicaid and Medicare.
At the end of the report that NAMI has authored, there are a number of recommendations. Does NAMI, in the words of my New York experience, does NAMI have a rabbi on Capitol Hill aside from the president, the commander-in-chief, who's going to be leaving office pretty soon? Is there among the congressional leadership or membership, folks there in favor of pushing the kind of recommendations in your report through?
Yeah. Well, we're fortunate to have several champions. Congressman Paul Tonko is actually from New York, is actually focused specifically on parity, and he has a Parity Act which will, I believe, be rolled out on May 14th in a hearing on Capitol Hill. Then we also have Congressman Tim Murphy, who's a Republican from Pennsylvania, and Senator Chris Murphy, just to make everything very confusing, who's a Democrat from Connecticut, who have comprehensive mental health legislation. I don't think Senator Murphy's legislation has been introduced yet, but I know he's working on it. Actually, neither of them have been introduced in this new Congress, but both are promising comprehensive mental health legislation, and we really need it because it's been a long time coming. We've needed this for decades. People who need mental health treatment find out the hard way that just when you're at the greatest need and you're most confused and most afraid, you're facing this very complex system where it's really hard to figure out which door to walk in and how to ask for help and how much it's going to cost you. So we need federal legislation that will make this whole thing easier. And then we also need state legislation that will help people access high quality health insurance and at